Our next speaker is Dr. Omar TARIQ. His education included Oxford and then the rest of his clinical work at Manchester. I know when I was speaking to him and trying to recruit him that I was very excited about your background, Dr. TARIQ, and believe me, it has paid off well for hopefully all of us. He has presented at international conferences. He has a definite interest in forensic, and particularly forensic adolescent, and also addiction psychiatry. He's been a great asset and resource for us in the area of young persons, and he is the lead clinician for the young persons program. He will speak on, well, I'll let you do it, but trauma will be part of this, and also some work and attachments we had with Dr. Khalid Al-Ansari from Qatar. Dr. TARIQ.
Assalamu alaikum wa rahmatullahi wa barakatuh. Bismillah, alhamdulillah, wa salatu wa salam ala rasulillah. Rabbi shrah li sadri wa yassir li amri wa hlul uqdatan min lisani yafqahu qawli. So thank you, Professor Wilkins, for the very nice introduction. So my name is Dr. Omar, and I'm going to be talking to you hopefully today about trauma and substance use. So I will give you a brief overview of this topic. I was fortunate enough, I think Lisa gave me a good kind of introduction and background to my talk, so it fits in well with that one. Okay. So unfortunately, I also have no conflicts of interest, so maybe Jeff, me and you can meet afterwards and think about how we can, get some conflicts of interest. Okay. So there is no trust more sacred than the one the world holds with children. There is no duty more important than ensuring that their rights are respected, that their welfare is protected, that their lives are free from fear and want, and that they grow up in peace. This was a statement made by Kofi Annan, who's the 7th Secretary General of the United Nations and co-recipient, along with the UN, of the 2001 Nobel Peace Prize. So being a child and adolescent psychiatrist, I'm very passionate about children, and we have a duty of care as parents, as adults, as a community to protect our children, as they are the most vulnerable members of our society. The last 2 to 3 decades has been a vibrant and energetic period during which a lot of wonderful research has been conducted worldwide, highlighting the potential harms that our children can experience or be exposed to, the devastating damage that trauma or harm can have on a child's development, and indeed consequences in adult life, and also the urgency with which we need to ensure that we have prevention and early intervention programs in place to minimize the risk or harm that our children can be exposed to, and also at the same time promote resilience and support their growth and development. So what are the learning objectives from my presentation? Well, I want to give you an overview of the association between childhood trauma and substance use. I'll talk a little bit about the evidence base and what the effects of trauma can be on children. Then I'll finish off just talking briefly about protection in terms of early intervention and prevention programs. And SCAP here stands for SIDRA Child Advocacy Program. So we have, I'm running a workshop with my colleague Tony from the SCAP team later on. So we'll have more of a chance, inshallah, to have a discussion about prevention. Okay, let me introduce to you this child called Anna. And this was when she was 2.5 years old. So you can see she's like any child, happy, seems to be enjoying herself. And this is Anna at the age of 30. So what happened? And I'm going to narrate to you her story in the words of her mother, who is a clinical psychologist in the United States and is a strong advocate for child protection and trauma-informed interventions. So at less than 3 years old, Anna was sexually abused. The abuse was severe, sadistic, perpetrated by trusted caregiver, occurred at early developmental stage, and continued for nearly 4 years. None of us were aware of or intervened in what was happening, and this happened in the 1960s. Additional traumatic events, cumulative traumas, occurred throughout her childhood and adolescence. She was, throughout her childhood, many adults and many healthcare professionals tried to help her, but none considered trauma. She was drinking heavily and engaging in polysubstance use to cope with her emotional turmoil. At the age of 13, Anna broke, and she was diagnosed with schizophrenia, and at the age of 15, she began psychiatric treatment. Again, no one in psychiatric services asked about or recognized what had happened to her. For 17 years, she was in the mental health system, of which she spent 11 years as an inpatient. For all those 17 years, no psychiatric treatments, alternative therapies, mental health services, or medications helped her. Throughout her long history in the mental health system, although she requested help for her trauma and believed herself to have PTSD, she was never assessed or treated for trauma. When she attempted to communicate the awful things that happened to her, there was no one in the service at the time to help, listen, understand her. As a result, she was continually misdiagnosed and considered to be, inverted commas, chronically mentally ill. No hope of healing was held out for her. On October 24th, 1992, at the age of 32, she committed suicide. So this is just one of many stories. Very heartbreaking story of a 30-year-old whose life was cut short because of the impact that trauma had on her. Okay, so how do we define trauma? Well, trauma or traumatic events are those incidents which cause overwhelming anxiety or distress and include experiencing physical, verbal, and emotional abuse or any other event that actually threatens death or serious injury to oneself or someone else. And we have a wide range of responses to trauma, which can include fear, helplessness, or horror. Okay, so there are different types of trauma. So we can have abuse, which includes physical, emotional, and sexual abuse. Children can be neglected or maltreated, and that's in the context of relational poverty. They may witness violence or domestic abuse. They may also have attachment difficulties because they don't have a safe and stable relationship with their primary caregiver. Okay, so there are lots of different effects of trauma on children, including issues with attachment, with biology, mood regulation, dissociation, behavioral control. So there's been a lot of research in terms, for example, mood regulation. So children who are exposed to trauma can have difficulties regulating their emotions. And I'll have a slide later on looking at the neurobiology of that. So you can imagine somebody who's experienced, for example, sexual trauma may then develop mood disorders. And in order to cope with those overwhelming feelings of guilt and low mood, they may resort to substance use. They term it as self-medication. Also, interestingly, is behavioral control. So this is, some people refer to it as the externalizing pathway. Keeps moving. It's quite sensitive, sorry. So children who are traumatized often are very impulsive, and they show poor impulse control. So they can start to engage in self-destructive behaviors rather than positive coping behaviors, which can also lead them down the path of substance use. Okay, so as I mentioned, if you lack positive coping strategies, you're more likely to engage in self-destructive strategies, which increases your risk of developing issues like substance use, alcoholism, mental health disorders, and suicide. I really like this diagram, and it's described as a trauma tree. I don't think you can see this laser very well, but basically, if you start at the bottom, the roots, they represent the prenatal stage of growth. And then when the tree touches the ground, that represents birth. Then the trunk represents early childhood. Then lower branches represent childhood. Upper branches, adolescence, and then you have adult life. So this, if you can imagine that when somebody experiences trauma, say for example at the prenatal stage or early childhood, then the growth of the tree, i.e. the brain development, will be adversely affected. So really the critical period is, obviously, if the roots are strong, then the tree will be strong. Now, if the roots and the trunk are damaged, then you're more likely to have a damaged tree. It's common sense. If we experience stress or trauma higher up the tree, then by that time, hopefully, we would have developed positive coping skills and life experiences to help us manage with stressful events better. So we need to focus on this area. Okay, so when children are sexually or physically violated, they often experience alterations in self-perception. And these are all drawings by children. So they often describe feelings of shame, guilt. They blame themselves. They think that they deserve to be abused. Sorry, it keeps moving. They describe themselves feeling bad. Often they describe a sense of contamination. They feel spoiled or degraded, and that they're evil. So I don't know if you can see, so I hate, and I always did, I think it says dad there. Yeah, you're no damn good. So there's a lot of negative internal emotions that these children experience. Okay, so what is the connection between childhood trauma and substance abuse? So research has shown that up to 2/3 of individuals who are in substance abuse treatment report that they have been physically, sexually, or emotionally abused. So this is hashtag end the drug war. This is actually giving the information that there's a stronger link between childhood trauma and addiction than there is between obesity and diabetes. So if you ask the average public, they will be more aware of the association between obesity and diabetes, probably, than between trauma and addiction. So we have a lot of work to do. Okay, so there's a strong gene-environment interaction, as with many disorders. So a lot of excellent work has come out of the United States. So University of Colorado has done genetic studies, family studies, twin studies, and what they've shown is that by adolescence, around 50% of alcoholism is related to genes, and the remaining 50% is related to a non-shared environment. And of that non-shared environment, virtually all of the cases are explained by physical, sexual, or emotional abuse. So this is a study by Bradley and colleagues. So they showed that childhood abuse, neglect, and trauma are linked to future substance abuse disorders at very high rates. So for example, heroin, around 6.5% is accounted for by abuse. Around 35% of cocaine addiction was because of childhood abuse. Almost 40% of alcoholism was as a direct result of childhood abuse or neglect or trauma. And for marijuana, it was even higher, almost 50%. Okay, so although it's unclear exactly how many adolescents who abuse drugs or alcohol have also experienced trauma, numerous studies have documented a correlation between trauma exposure and substance abuse in adolescents. So for example, in the United States, they do the National Survey of Adolescents, and what they've demonstrated is that those individuals, those adolescents who've experienced physical or sexual abuse, they're 3 times more likely to report past or current substance abuse than those without a history of trauma. Dakin and colleagues and Funk et al. Also surveyed adolescents who were in treatment for substance use. And what they showed was that more than 70% had a history of trauma exposure. And the correlation is particularly strong for adolescents with post-traumatic stress disorder. Okay, so what we know is traumatic stress and substance abuse problems commonly co-occur among adolescents. And Kilpatrick et al. Showed that the overall rates of co-occurrence between PTSD and substance abuse can be as high as almost 30%, so almost a third. And the co-occurrence is even greater in treatment settings when we look at females. So this is another review by Cormier in 2000. So he collected data from substance abusing women from 9 treatment centers across Ontario. And if you look, more than 50% reported childhood sexual abuse and more than 50% reported childhood physical abuse. Okay, just the point to focus on here is teenagers who have issues with substance use are 6 to 12 times more likely to have been physically abused, and this risk is higher when it comes to sexual abuse. So significant. Okay, so multiple pathways have been proposed to explain the temporal link between trauma and substance abuse in adolescents. So if you review these theories, what they say is that trauma and substance use, the path runs both ways. So what that means is that if you experience trauma, you're much more likely or you're at increased risk of substance abuse. And indeed, if you're engaging in substance abuse, you're at increased risk or likelihood of experiencing trauma or being a victim of trauma. Okay, so this is a PET scan. So PET scan measures important body functions like blood flow, glucose metabolism, and oxygen. So this is the front of the brain, this is the back of the brain, and here you have the key in terms of the activities in the brain. So this is the PET scan of a brain of a normal 5-year-old child. So at birth, only primitive structures such as the brainstem are fully functional, and the temporal lobes here, which are important for emotional regulation, they develop over time, and childhood experiences are an important factor in how these regions of the brain develop. Now, on this side, you have a Romanian orphan. So in Europe, a lot of studies have come out from Romanian orphans who were institutionalized shortly after birth. Okay. And what they show here is that the regions represented by the temporal lobes are quiescent. So these children will develop issues with emotional regulation and cognitive problems, which can lead them down a path of substance use. Okay, so there's also been a paradigm shift in our understanding of the neurobiology. So on the left here, this is the amygdala. So the old model was thinking about the fear circuit in the brain and associated fear, arousal, and emotions. And the main focus was to attenuate the fear response. Now, the newer thinking is that actually, when children fail to seek safety or security, what happens is that this is the reward mechanism or pathway. So you have the nucleus accumbens, VTA, and prefrontal cortex. So this is implicated, or this is activated when children feel safe. So you can imagine, and also this is the same pathway that is implicated in substance use. So you can imagine what happens is to a child who is abused, so they won't have this pathway activated. They then may engage in substance use to get this pathway activated. So a way to prevent that is to try and minimize abuse that our children may experience. So the ACE study, this is really the landmark study, and it was a decade-long collaboration between Dr. Vincent Felitti from Kaiser Permanente and also Dr. Ander from the CDC. So Dr. Felitti, he actually ran an obesity clinic in San Diego, and he was really interested to study why the people who were losing the weight, who were getting the best results, were dropping out of the study. And when he looked into it, he found over and over again that most of these individuals had a history of sexual trauma predominantly, but also other types of trauma. So then a larger study design was conceived, and then you have the ACE study, which is the largest study of its kind, examining the health and social effects of adverse childhood experiences. And in the initial wave, they had 17,000 respondents. So what they did, they divided ACEs into 3 categories: abuse, household challenges, and neglect. So abuse included emotional abuse, physical abuse, sexual abuse, and then neglect included emotional and physical neglect. Household challenges was children who were brought up in an environment where there was, where there was mental illness, separation or divorce, substance abuse, and violence. So most of the people who report, almost 2/3 of the respondents reported experiencing an adverse childhood experience, and of those who reported one, the majority reported more than one. Okay, and there appears to be a dose-response relationship. So the more ACEs you have, the higher the risk of medical, psychological, and social problems in adult life. Okay, here this table on the right, this compares the risk of an individual who has an ACE score of 4 as compared to an individual who has no ACE. So if you look at illicit drug use, there's a 443% increased risk, and even higher to become an intravenous drug user. So there's a very strong association between ACEs and substance use. And here is the probability of outcome. So for given 100 American adults, 16 would experience 4 to 8 ACEs. And if you compare how many would be alcoholic in this group, 1 in 6, to those with no ACEs, 1 in 69. So again, there's a significant increased risk. This table or this graph shows the ACE score and the percent alcoholic. So the higher the ACE score, the more likely you are to become an alcoholic as an adult. And they said that there was a 500% increase in alcoholism was related directly to ACEs. Okay, so again, if you look at this graph here, the more ACEs you have, the higher the risk of having issues with substance use, including early initiation of alcohol use, problem drinking, increased likelihood of early smoking, prescription use, lifetime illicit drug use, ever having a drug problem, and self-reported addiction. So there's also a dose-response relationship. So between the number of ACEs and the risk of initiating drug use under the age of 18. So this shows the association between the ACE score and becoming an intravenous drug user. A male child is still doing the same thing. A male child with an ACE score of 6 has a 4,600% increased risk of becoming an intravenous drug user. Okay, so what's the mechanism by which ACEs can lead to problems? Well, when children are exposed to chronic stressful events, their neurodevelopment can be disrupted, and disruption in early development may impede a child's ability to cope with negative emotions, which can then result in cognitive and emotional problems. Eventually, over time and during adolescence, usually they develop self-destructive behaviors such as suicidality or substance use, and then that can lead to problems in adult life, including premature mortality. So what can we do? Well, we need to have a public health approach. We need to think about prevention. So we need to try and think about how we can stop abuse happening in the first place, and that's through psychoeducation programs, through engaging communities, through engaging schools and the wider community to think about this sensitive topic. We need to then also think about detection and early intervention. So once we do suspect abuse or neglect or trauma, then we need to act quickly so that we can minimize the damage. And then we need to create environments where children feel safe and where we can promote their resilience and growth and development. So these are some pictures from a public health approach to abuse in Saudi Arabia, which I came across over the internet, and I really liked it. So it talks about, children's bodies belonging to themselves, not sitting on the lap of a stranger. Also, this picture here, kind of if you're offered sweets, not to respond every time. So this is a really positive move, really, to increase awareness about this issue. So this is a really amazing resource produced by NIDA, and it gives us guidance on how we can prevent drug use in young people, which is research-based. And it gives a number of principles. For example, it talks about prevention programs enhancing protective factors and reversing or reducing risk factors. So what we can do as educators, as policymakers, as healthcare providers, is we can use these principles to think, plan, and deliver intervention programs at the community level. They also give this really nice table in terms of how do we assess if a community is ready for an intervention program looking at substance use. And I think in Qatar, we're very fortunate that we have visionary leaders, Dr. Khalid Al-Ansari from Sidra, who unfortunately couldn't be here today, but we have Tony from his team, and we'll be doing a workshop later on. Who are working really hard with all the stakeholders, including Naufar young persons. We've been working collaboratively to try and address this difficult issue. Okay, so my really take-home message is we need to invest in our children. The issue is not are we going to pay, it's whether we're going to pay now or whether we're going to pay later on when it will be a lot more. And the solution of adult problems tomorrow depends in large measure upon the way our children grow up today. Thank you.
Questions, please.
Thanks, Dr. Omar. My question is, you kind of identified that identifying and then intervening early would change the prognosis where there's evidence of childhood trauma. What are some of the interventions and what can be the evidenced outcome in the event you're able to get to the child before they start engaging in self-destructive or addictive behaviours.
Okay, so intervention programs, I guess, is, for example, the Sidra Child Advocacy Program. It's a program designed to basically intervene, investigate suspected abuse, okay? And then once you do investigate and you confirm, then it's about how we promote the resilience of that child or young person, how we support their growth and development, whilst also addressing the trauma. Because the longer we leave the trauma, the longer they are, the higher the risk of them developing maladaptive coping strategies. So it's really about the children feeling that they can be heard, and that this issue, because a lot of them, they won't express, or they won't be able to articulate what's happened to them. So I guess I think in the workshop we'll probably address this a bit more. We'll have more time to talk about it. So does that answer your question?
Yeah, thank you.
Thank you for that presentation. I fully agree with your three. It's very important because Freud talked about trauma early in childhood. And trauma, according to Freud, from the psychoanalytic perspective, is the basis for anxiety later on. I have, in fact, three concerns.
Okay.
The first one is trauma. What is trauma? Definition of trauma. Well, I fully agree with the Western definition that you have raised, which is based on the SMs and the history of that. However, the challenge is using the same definition of trauma applied to our context. And I can claim, and I published 3 articles about that definition of a trauma is not applied to our context because we have our own terminology. Now, if we translate trauma into Arabic words, means sadma, and we use sadma in loose terminology, okay? And we use another terminology for definition of sadma, which is sadma, faja, and musiba, and that's the research indicates, the qualitative study that we have done. So I think we have to be very careful in defining and applying definition of a trauma. That's one. Second concern is the instrument that we use. I mean, the most common valid trauma questionnaire is the Harvard Trauma Questionnaire, and we all use that and it's translated. I am not questioning the statistical validity of that. The trouble is applying that to this culture and this context. And here we can question the cultural validity and meaning of the items, and that's another challenge. And that's why in the SM5, they have tried to ratify this by the cultural formulation and for before. So I hope maybe we can consider these when we present, especially in this context.
I think
the third concern, then I'll give you the floor. The third concern is when it comes to the 3 that you've mentioned, is very important. However, we have missing something very important. And this is based on the definition of a trauma, which is resilience. So where is the resilience part of it? And the first presentation, our colleague from Italy presented the multifactorial to drug abuse, which is very, very important. That we are not ignoring the biological aspect of it. However, we have some other factors that we have considered. And if we follow the trauma, based on your presentation and the previous presentation, the definition of a trauma has to be validated, culturally validated. Okay. Thank you.
Thank you very much. Just to answer your concerns, I think one thing is when we talk about trauma, and most of the research, it's retrospective, right? So the individuals are already in substance abuse treatment who are then diagnosed with PTSD or other trauma. So when you look at their developmental history, then you understand that they've gone through a lot of negative life experiences. So what I'm talking about is not reaching to that stage. How do we stop individuals going down that trajectory? So I guess I was using the terms interchangeably, trauma and abuse. So being a child psychiatrist, I'm more interested in first of all, raising awareness about abuse, and specifically abuse, because that's a lot of trauma comes from abuse. And then secondly is how do we intervene to avoid them developing negative outcomes as adults? Okay. But thank you very much for your concerns.
Thank you very much, Dr. Omar.
Thank you.